Good afternoon. I'd like to welcome and introduce Dr. Robert Murphy, Executive Director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine, who answers your COVID questions every Wednesday on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be answering viewer-submitted questions and addressing the latest COVID headlines through today, January 13th. We invite you to submit your COVID questions via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. Leading the discussion today is myself, Sylvia Bukowski, a student research assistant with the Institute. So, Dr. Murphy, I'm going to start with some updated COVID statistics.
Great. Good morning.
In Illinois, yesterday, we saw 97,000 positive new cases, with our 7-day average at about 60,610 positive new cases every week. We have a 4% increase over the last 7 days. Hospitalizations have increased by 9%. The death rate in the US has increased by 61%, with our daily average of deaths at about 564 deaths per day. So, Dr. Murphy, what can you tell us about what is going on in the United States right now, and with Illinois not even reporting cases that often anymore?
Yeah, there's a couple things going on. Number one, we're reporting less frequently, so you're going to see more jumps in the numbers. But this is the winter wave. This is what has been predicted all along. This is the post-season increase in infections. This is because of the new variants that are out there that are even more easily transmitted. You put all that together, it was predicted, the numbers go up. First, the cases go up, then the hospitalization rate goes up, then the death rate goes up. So that's exactly what's happening now as we it's the impact of the season. I think particularly with the death rate going up that much, but remember, we were down around 300 cases, approximately per day dying. So, the numbers were relatively low. And so a bump up is going to see a big increase in percentage. Still 500 cases a day. I mean, it's terrible, but it's nothing like what it was before. We still have plenty of capacity in the hospitals. The pediatrics is pretty full, but in the adults, there's plenty of capacity in the system in almost all parts of the country. So we have to watch very closely. We'll see what happens over the next couple of weeks. We should see this peak, and then it should come back down by the end of February, beginning of March. And that wave will end, the weather will start to get better, and we'll see a continued downslope, most likely.
Wonderful. Well, that's really good to hear. So, Dr. Murphy, going into our first COVID headline, it is a discussion for our first COVID headline of, do younger, healthy people need another COVID booster? There's a couple of vaccine experts that are now weighing.
Yeah. So Dr. Offit from the University of Pennsylvania, pediatrician, very respected vaccine expert, contradicts, his opinion contradicts the Centers for Disease Control guidelines, in that everybody who's eligible for vaccine should be getting the new booster, which came out in September. So the new booster is a different vaccine. It's geared towards the Omicron variants, which is what's circulating now. Plus, half of the vaccine is the older vaccine, the original vaccine. There's no question that older adults and that people with underlying immunocompromised conditions and diseases should be getting the vaccine. Absolutely no. There's no question there. What he's saying here is that younger, healthy people may not need this vaccine. And he has reviewed the data, which is all public. And he says, it's really not going to make much difference. Well, yeah, right. That's true. Younger people don't tend to get sick as much as older people. And so the impact is going to be really hard to measure. However, it can still affect how many infections are floating in a community and how many people get infected. And it will help in the bigger picture of things if just everybody gets this booster now versus just segments of the population. So I think it's a healthy discussion, but the CDC, believes that the way you're looking at this is considered selective, and that they're sticking with their guidelines that recommends that everyone is going to need this newer booster. Now, every year you get a new vaccine for flu. The same is going to happen with COVID. And so there's nothing really new there. I'm healthy, I'm young, I don't need a flu vaccine. Okay, that doesn't work in public health. That's an individual choice, but for the population at large, that still puts other people at risk. And so that's why, the annual vaccine is recommended for flu, and most likely that's going to happen with COVID. So I think it's a healthy discussion, but it doesn't mean that people shouldn't take the vaccine, and especially if you have any kind of underlying disease or any condition like obesity, or you're over 50 years of age, all those people should be taking the vaccine, and the uptake for the vaccines is very low. So we're way behind in getting people vaccinated.
No, absolutely. Well, going into our next COVID headline, which once again ties closely into why it's necessary to get vaccinated, is that health experts are looking closely at XBB.1.5, the latest Omicron subvariant. So what can you tell us about what's going on with that?
Yeah, this subvariant of BA.5 is one of the Omicron variants, is very, very infectious. It's even more infectious than the last one. It accounts for 72% of the cases in the Northeast of the United States, about 20% across the whole country, and this will be across the whole country shortly. Now, as these viruses mutate, the virus sometimes has to pay a steep price. And in this case, perhaps because the whole thing is mutating so much that perhaps it'll be, a milder virus, a less virulent type of virus. That remains to be seen. But, unless we see some big jump up in hospitalization and death rates, more than what we expect just from the winter bump, that's definitely not the case. So we'll see what happens with this too. And there's going to be another variant after this. So, ultimately this thing may just hopefully mutate itself down into a dull war that, is just something endemic that we can live with.
Yeah, no, absolutely. And going into our last COVID headline is that the Biden administration is now renewing the COVID-19 public health emergency. So what does this do for the resources, etc.?
Yeah, no. Well, this is good. This is just a public health policy that the public health emergency is still there, that gives the federal government all sorts of different authorities over COVID, including data tracking, allowing pharmacists rather than physicians to give the COVID vaccine, and all sorts of other kind of emergency provisions. Maybe this stuff should just be standard of care. We're learning a lot because of this pandemic. And maybe, we can learn from this. I mean, more people now mostly are getting diagnosed, not even in doctors' offices. They're getting diagnosed at these clinics that are in pharmacies and in retail stores. And, as the tests get better and faster, it might just be easy, to get all your tests and vaccines at places like that. So I think it's a good thing to keep this going, because the pandemic is not done with us.
Right. No, that's very true. And going into our first COVID headline, or first COVID question, I apologize, is that this individual says that they had COVID in August of 2022. They took Paxlovid and had a mild case. They are 66 and fully vaccinated. If they get COVID again now, Dr. Murphy, will they be able to take Paxlovid again?
Great question. And absolutely, this has been looked at. In other words, the issue would be, if you took Paxlovid once, you got better, then you got sick again, would the drug work? In other words, would it have developed resistance already? And so far, looking at cases after a subsequent treatment with Paxlovid, they have not really identified any resistant strains. So that's great. That's great news. So you can take it again, and you should take it again. So that's good. People have taken it after a rebound, and then this is not a rebound case. This is a second case. But in either instance, it's been looked at, and there's been no drug resistance.
Wonderful. And going into our second and last viewer submitted question is, are there any studies showing causation or reports warning possible causation for Pfizer vaccine / booster and strokes? What can you tell us about this, Dr. Murphy?
Yeah, I think what you're referring to is an article in Lancet that came out recently from a study in Hong Kong that actually looked at a total of over 5 million doses of the Pfizer and 3 million doses of the Coronavax. And they measured the amount of thromboembolic events, blood clots, and hemorrhagic strokes. And they were about the same for each one of those vaccines. And there was a potential, there was a, what they call it, a possible safety signal with the Pfizer vaccine and the strokes. Now, to make it clear, this rate is much less, is much lower, significantly lower than if you got COVID. So COVID is associated with blood clots. We've known that from the beginning. Heart attacks, strokes, and everything else. So it's always balancing, you know, the ratio between the risk and benefit. And, you know, getting COVID is very high risk for these kind of events, strokes, heart attacks, whatever. Vaccine may be associated or linked in that. Right now, they don't know if it's actually causative or it's another kind of a link, but it's definitely smaller than if you get COVID. So if you don't take the vaccines, you're more likely to get COVID and more likely to have a more serious run of COVID, where you're going to get these blood clot type side effects. So I think in the end of the day, you know, you don't want to not take the vaccine because of a potential side effect. And you're talking about 334 thromboembolic events out of 5.5 million. You know, and as far as a hemorrhagic stroke, a stroke that actually caused bleeding, that 57 out of 5.5 million, 57, just two digits, 57. So, you know, you do these population studies, you know, the percentage, your risk is really very low, and it's lower than if you get COVID.
Yeah, it's entirely true. Well, Dr. Murphy, thank you so much, and we will see you next week.
See you next week.
Bye.